Thanks, Eva. Pleasure to be here. Can everybody hear me in back? Great. I've been asked to turn down the mic in situations where I was talking without a mic, so I do want to be careful. I think the title in the program for this talk is Challenges and Opportunities in Health Analytics. And that is what I'm going to talk about, but that health analytics is a huge topic, and it covers a tremendous range. So I want to focus, for your benefit, I'll focus on the area I know best, which is healthcare providers in general, and hospitals and other large healthcare systems, with focused on hospitals in particular. I also want to focus in on recent events in the industry and in the United States, and this is going to be a US-centric healthcare talk. In the United States, it's all about healthcare reform. So as you know, as many of you know, there was major legislation passed just a few years ago. Most of it is coming into effect in 2014. And if you are the average hospital CEO, COO, CMO, Chief Medical Officer, or CFO, you are scrambling, you have been scrambling for the last several years and are scrambling now to figure out what the world of healthcare is going to look like after healthcare reform kicks in and how to actually run a hospital or a health system in that context. And there is a wide perception of the healthcare industry that analytics can help. And I'm going to really focus in on that with a particular focus on, and this is just a very quick overview of really the three sort of major sections of my presentation. One's going to be just a brief primer on what healthcare's reform's impact on hospitals is going to be. For those of you that are in the healthcare industry, some of this may be basic, but I'm going to give you a broad, high-level view of what's going on. If you're not in the healthcare industry, some of this will be an eye-opener. I'm going to talk broadly about healthcare business analytics. And so, for instance, there are different flavors of analytics in the health space. We've heard presentations from people like Professor Lee around medical applications where you're actually using analytics to improve care, to design better care. There certainly is first-rate work going on in pharmaceutical side of the industry and medical device industry that uses those sorts of analytics, and that's important work. I'm going to talk more about the business of running a hospital and talk about a hospital as a business. Also, I'm going to tend to focus more on what I would call strategic level decisions as opposed to operational decisions. So, for instance, this morning there was a really excellent presentation in the first session on using predictive analytics to maximize your understanding of waiting times or surgical times in surgery suites so that you can maximize flow of patients and utilization of limited surgical suites. Really important operational problem, really critical to hospital operations. Having said that, the type of decision I tend to focus on is much more around how did you decide to build 12 surgical operating rooms rather than 16. Because if you really want to move the dial, add more resources of the right kind. So what's the right kind? How do we configure correctly for what's going to happen over the next 5, 10, 20 years, and put the right infrastructure in place, make those level of decisions. And that's going to be much more my focus. I'll also talk a little bit about experience from the company that I've been involved with running for the last 17 years, called Strata Decision Technology. We're actually a software company first and foremost, and we provide solutions to help hospitals do business analytics, particularly in this sort of strategic finance space I just talked about. And then I'll wrap up with some more speculative ideas about where I think healthcare business planning might go as we improve it and grow our capabilities in this area. So what does healthcare reform do to hospitals? In a nutshell, and I'll talk about each of these in more detail in a second, it expands access to care. That was really one of the major rationales for why we have healthcare reform. it's changing the way hospitals and healthcare providers get paid for the care they provide in very important ways. And then finally, and this isn't directly caused by healthcare reform, but it's partly happening at the same time and partly being driven to an even greater level by healthcare reform. There's a massive buildup in healthcare IT capabilities, spend, and it's been widely recognized as an important component of what the industry needs to do next. So, what do I mean by saying healthcare reform means better access? Well, millions of uninsured Americans who have no means of paying for care, are now going to have access to some form of paid care. Okay, that's going to happen really through two major mechanisms, one of which is already underway, which is an expansion of the government Medicaid programs. And it's a complicated world of government programs. These are primarily administered as federally funded but state-administered programs in each state. And some states, not all states, are electing to expand the eligibility requirements so that more people qualify for Medicaid. Medicaid is the program which is aid to people who don't have the means, usually because of income or employment status, or both, to pay for care themselves. So expanding the number of people eligible for Medicaid provides one source of payment for care. The other thing is a mechanism that will be going live toward the end of this year with insurance coverage effective in 2014, namely something called health insurance exchanges, which the details are messy, but in a nutshell, it's about basically places where, mostly online places where people can go, administered by either state or federal authorities, and there's a story we could tell about state or federal authorities there. States can elect to do their own or can opt into a federal system where they'll be able to buy, individuals and families will be able to buy health insurance policies who might, and those will have some subsidies attached to them if you qualify for income conditions. And so you will be able to more easily buy individual health coverage if you're not someone who's either eligible for a government program or whose employers provide them insurance, which is the dominant form of health insurance coverage in the United States. I'm trying to fill in a little background on how the U.S. healthcare system works for the benefit of people in the audience who may not be familiar with our health system. What's the impact going to be on hospitals and other healthcare providers? If anybody knows for sure, let me know, because I've got a number of hospital CFOs that really want the answer. But here's sort of the received wisdom of where things are going. There's going to be a tremendous surge of demand for what we would call non-emergency care. Right now in the United States, anybody who needs care, who thinks they need care, can walk into an emergency room and be taken care of, independent of whether or not they've got an insurance card in their wallet, independent of whether they've got any means to pay for the care, to pay a bill at the end. Okay, so that's the sort of healthcare provider of last resort. And if you live in a big city in particular and wander into an emergency room, that's why there's all sorts of interesting people there and very long waiting lines and a tremendous amount of congestion. Okay. Is that the most efficient, effective way to take care of people? Well, no. It would be really nice if you could see somebody who has type 2 diabetes in a physician's office and get them regular care over a period of time and not have them have to wander into the emergency room when they're in a health crisis and haven't seen a doctor in a year and haven't received care and have been sort of not necessarily very effective in taking care of themselves, and so on and so forth. The other thing that's going to happen is the relative utilization of care is going to shift from emergency rooms and hospital wards to doctor's offices. Why? Well, people who don't have any way to pay for care tend not to go to the doctor's office, and they will go to the hospital when they have a critical situation and figure out how to pay or not for care at that point. But it will be better, more effective if they're able to see doctors for things like preventative care rather than getting to a point where there's serious care later on. And then finally, nobody's quite sure what these health insurance exchanges are going to look like, what the policies are going to look like. Insurance companies, I don't know if there's anybody here from the payer the insurance side of healthcare here. But they're working out, even as we speak, what the precise look of those policies are going to be. Received wisdom is that they will generally be cheaper than the kind of care you could buy retail yourself or that your employers provide you now. But they will also provide more limited services up to a point, and in particular more limited choices of providers. So they are going to negotiate, the insurance companies are going to negotiate contracts with select providers, pay them a lower rate, extract a greater discount, but say, and we're going to limit, so we're going to force folks that have the exchange policies to come to you rather than being able to choose any doctor they want or any from a broader range of doctors. So narrower choice. Ultimately, the hospitals that make those contracts will get paid a lower rate. How low, nobody knows. Just to give you a sense of this, Medicaid already pays in most parts of the country, if you're lucky, 60 or 70 cents on the dollar relative to the cost of providing care. And hospitals subsidize that by charging more to folks with insurance cards from their employer. So your employer pays a hidden tax, essentially, to pay for people that have no insurance or that have Medicaid coverage. Insurance exchanges, maybe they'll pay more, maybe they'll pay less. They certainly won't pay what your employer pays for care. Maybe they'll pay more than Medicaid, but nobody's quite sure. So a lot of uncertainty there. This is also shifting the payment model. Okay? Right now, the dominant model has been fee-for-service. You go to the hospital, and the hospital gets paid based on whether you show up or not and how many things they do to you, how many procedures. Think about the incentives there. Okay? The hospital's incentive is to get as many patients in the door and to do as much as possible. Not that they'll provide, not that your doctors will order unnecessary care, at least one would hope, but still there's no incentive there for the doctor to provide less care, perhaps just the opposite. We're shifting to a model called fee for value, trying to pay providers based on the value they deliver to patients in terms of low cost, but also more importantly, and this is the big difference, better outcomes. Okay, imagine that, getting paid based on the quality of what you do as well as what you do, the amount of activity you perform. Some of this involves very new delivery models, something called an accountable care organization. One of the things this is doing is shifting risk from the insurance company to the hospital provider. So you get a whole population of patients, a group of patients, and you're told, take care of them, we will pay you a fixed fee. It's sometimes referred to as a capitated payment, a per member per month fee, and you will then, and then you will then take care of these patients. You're at risk. You don't know how often they'll need to be hospitalized. You don't know how often they'll show up at the doctor's office. You don't know what procedures they're going to need. When you do encounter them, you have to estimate that and then try to price out your contract appropriately with the insurance company, who, by the way, has better tools and actuarial tools to deal with some of this, or at least they think they do. They certainly have more data. So there's a challenge there. And then also a component of the payment, and this may sound a little bit like an old model called an HMO, a health maintenance organization that's still around in various forms, was very, very popular for a while and then became disreputable, because in the old model, in the HMO model, basically the hospital incentives went from being paid for providing more care to being paid to not being paid anymore related to volume of care. And so therefore, what was the incentive? It was to provide less care. And the ACO model, in theory, how this plays out in practice, nobody's quite sure yet, but the ACO model, in theory, has that same structure, but also an additional layer in that the providers will be paid based on outcomes as well. So if there's high complication rates, high death rates from certain procedures and surgical procedures or whatever it might be, they'll get paid less. If they get good outcomes, shorter stays, but also better results, fewer readmissions, fewer hospital-acquired infections, better result, and measurably better quality results, they'll get paid more. Okay, so now that's countervailing the tendency in an HMO for doctors to want to provide less care, or at least to have to struggle not to be forced to provide less care. And so it's changing the dynamics, changing the incentives in a fundamental way. So in the old fee-for-service model, just to run through the dynamics, what was your incentive? Well, a hospital would want to target payers that, so they can generate more revenue, bring more patients. The gentleman from Boeing this morning referred to butts and seats. You want butts and beds. You want to get more patients in the door. Why? You'll get paid more. You'll need to do more procedures to take care of more people. Fee for value, with a growing component of revenue tied to quality, better outcomes are going to lead to more revenue. So you're going to have to invest in outcomes and quality in a way, not that you didn't care about quality before, but it's now part of your business model in a very core fundamental way. You're going to have to deal with capitated payments, with these limited payments, taking on more risk. And there won't be any incentive for additional care unless there's also better outcomes associated with that additional care. And the two imperatives then in that world for hospitals is managing quality very actively, very proactively, and managing cost very actively, very proactively. In the words of one hospital CFO that I know, cost is cool again. The only thing I don't like about that quote is I'm not sure it was ever cool to begin with, but that's a side issue. So, other things that are changing here in terms of how you plan in a hospital context for this type of thing. Well, you have to plan across cost settings. So if you think about putting together a budget, putting together an operating plan, or even a high-level service line strategy, the way hospitals always thought about the world was in silos. Okay, my hospital is different from a physician practice, which is an independent entity out there. Hospitals have run out and bought physician practices or built them themselves, so that hospitals now employ physicians rather than having physicians essentially as independent contractors that are out there running their own business. Okay, so it's a single organization, much more integrated across all the settings of care. So a hospital system will own physician practices, they'll own long-term care facilities, and everything in between, rehab facilities and so on. Maybe many of you have probably seen this in your communities. And so now the emphasis is on planning across the settings of care. So instead of vertically in the silo, saying my hospital or my department within the hospital, you start to think of the world in terms of service lines. Orthopedics, from the doctor's office to the hospital ward in the operating room, to the rehab facility afterwards, and so on. Okay, so you start to think about cardiology the same way, oncology, pediatrics, and so on. Or you might think of in terms of population, because you are contracting to take care of a group of patients. You start thinking about managing the health of that population, even if at the level of an individual episode or condition, diabetic patients across that horizontal range. There's also going to be a gradual shift in this payment model from volume-based to value-based, okay? And although I have a crossing point in 2014, nobody knows what the final equilibrium is going to look like, what the balance between volume and value is going to be, how much fee-for-service is not going away completely. Right now, it's still the dominant form of payment, okay? But having said that, everybody knows fee-for-value is coming and it's going to become larger and larger. How quickly will it get there? When will it become the dominant model? Nobody knows for sure. So there's a lot of uncertainty there. And so there's going to be less, in the old model, there was a lot of emphasis on revenue cycle management, making sure that you got paid everything you were entitled to from the insurance company, or if the person didn't have insurance, we're talking about bill collections, and trying to get paid as much as possible in those situations. And now we're much more focused on cost and outcomes. Why? Because cost and quality are going to be the critical factors. Not that revenue doesn't matter anymore, but it's cost and outcomes is really the critical issues. Now let me turn finally to IT and then move on to get a little more into the guts of the analytics. But this is where analytics comes in. The shortest way to say this is compared to, for those of you that aren't in healthcare, I don't care what industry you're in, healthcare is way behind on IT. Way behind. I know of some 20 or 25 hospital systems that have only recently started implementation on their first ERP. Okay. Most hospitals started within the last decade, or I should probably say completed within the last decade. So they're still very early in the process of going with enterprise planning systems. Okay. How many people only started their other than a startup business, only started their very first ERP implementation within the last 10 years? Okay. If you're not in healthcare, the answer is probably no. You've been doing it for quite a while. Maybe it's not the same system or the same vendor or the same capabilities, but you've been there for a while. Okay. The other big piece of IT in the hospital setting is EHRs, electronic health records. And maybe you've heard something about this because when the stimulus money came out in the economic downturn, there was a specific chunk set aside to essentially subsidize the cost of acquiring electronic health record systems at US hospitals. Why? Because they weren't doing it on their own. And there was a perception that until you get patient records into a database, rather than lots of paper files, it's going to be really hard to do any kind of sophisticated analytics to really even just measure things like outcomes. Why? Because it's buried in the doctor's notes, and if it's on paper, we all understand that that doesn't work. Okay, everybody in this room understands. Okay, so this is a necessary precondition for getting analytics into healthcare, into hospitals and physicians' offices. If you don't have the IT infrastructure in place, just try to analyze it. Okay? You can do it, but it takes a very long time and is very, very painful. So they're late adopters on ERP. They're still running some fairly obsolete systems out there. EHRs, they're massively, massively doing this. Why? Because the way the stimulus was set up, they had to start in 2010, 2011, and they have to finish by 2016, or else. They're getting paid a fraction of the cost of putting an ERP in, by the way. And I had a conversation with the CFO of the Johns Hopkins healthcare system, where his total cost of putting in a system-wide ERP was $1 billion. About half of that goes to the vendor, but then think about the implementation costs. Okay, particularly because some of these systems aren't that easy to implement, and you have to train and change processes with almost every part of your organization that faces the patient, which is basically your whole organization. Okay? And there's also back-end changes in processes and supply chain and pharmaceutical distribution and other things that go along with that as you start to automate things that previously were manual and so on. Okay, so people are now anticipating that this is all going to be coming in place over the next few years, and there's going to be a massive adoption. So the old problem in the healthcare industry was we don't have any data, and there's starting to be a realization of the new problem is going to be now we have data. Okay, so in some sense there's an anticipated big data problem. It's not a big data problem yet, it's an anticipated big data problem. So, and the term that one CIO I spoke with used was, we're all going to be data rich and information poor, because we're not going to know what the hell to do with the data. Okay, so you've heard that story before in other spaces and in your own industries, I'm sure. Hopefully you're further along than healthcare is in dealing with this. So one report I saw, and this gives you a sense of the scope, as of 2011 they estimated about 1/3 of US healthcare providers had some kind of electronic health record in place, and essentially they're anticipating that virtually all of them will by 2016. Okay? And then in terms of who's going to be putting in place what they call health data analytics tools, which I think we would translate in terms of how they defined it in their report, into a much broader set of analytics tools, including but not limited to advanced analytics. Right now it's probably around 10%, and they think it's going to be about 50%. Okay, so this is a slow process, and they're still at a very early stage. If you use the language of maturity models, healthcare is low on the maturity hierarchy, by and large. There are exceptions, some of whom have won Informs prizes and Edelman Awards and so on, but those are the exceptions. So what's the bottom line? Well, according to the American Hospital Association, the average not-for-profit hospital in the U.S., and that's most of the hospitals in the U.S. are not-for-profit, most of the non-governmental hospitals in the U.S. are not-for-profit. The average operating margin is 2%, and 1/3 of them, at least in 2011 when this report was done, had negative operating margins. Okay. So they're being asked to make massive spend on IT, to start investing in quality, to reinvent their business model in the context of extraordinarily thin operating margins. Okay? And so it's just imperative, as all of this stuff takes hold, that they take cost out and improve quality and outcomes both. So let me talk a little bit about lessons learned, just really quick background on my company. This is not about, this presentation is not about my company, but I'm using examples, so let me give you the context. We are a software as a service provider, so we develop software hosted on our own servers and provided to hospitals and healthcare systems. And we work primarily with the CFO's organization in hospitals, with the finance suite. And so we work on budgeting, planning, and so on. Work with about 1,000 hospitals. To give you a sense of that, there's probably about 5,000 to 6,000 non-government, so non-VA, non-military hospitals in the U.S. And we think we work with about 1 in 4 of the larger hospitals and healthcare systems. We tend not to work with small rural facilities and things like that. It's a national client base. For those of you in the back of the room, if you could read this, you would almost certainly see a hospital in your neighborhood. Christus Health, and they have a hospital somewhere in this general area of downtown San Antonio. Part of the Santa Rosa system, has been a client for many years. And a number of other names you would recognize, including names like Johns Hopkins, Cleveland Clinic, or Mountain Health out in Utah, and so on. And we've worked really across the spectrum of descriptive, predictive, and prescriptive business analytics. Planning, budgeting, reporting, support. This is a graphic on the right that I refer to as the great blue marble of healthcare business planning. We provide budgeting, capital equipment or capital budgeting and resource allocation, management and productivity reporting, strategic planning, which really means long-term and near-term forecasting of financial performance and performance improvement. And then cost accounting and decision support, which is our latest area. The odd thing in our history is, and maybe this isn't odd given I was a prescriptive analytics guy by training and inclination, is we started at prescriptive, then wandered into predictive, and now we're moving down to descriptive and getting heavily involved in that. And so, you know, a skeptic would say, well, he's too old to optimize anymore, but I still know how and like to do optimization, but this is, you go where your customers take you. And the number that are ready for prescriptive analytics isn't necessarily where the business is. You want to solve the problems the clients have, right? So now let me give you a sort of a high-level architecture of what a business analytics software stack might look like in a hospital context. This is not a great insight, but there's a lot of different data sources out there, and right now there are actually a lot of disparate systems. So they don't have a single enterprise platform yet. They don't have a single clinical platform with their health records and so on. They've got separate GLs, but budgeting, purchasing, and on the clinical side, different clinical systems, some of which are highly specialized, some of which are broader across the whole organization, and so on. And they have a lot of external data feeds. And so you have all these various data marts, financial, operational, clinical, market data that the planning people are using, demographics and things like that, as well as all sorts of other stuff. Third-party providers, supply chain partners, people like that that are providing information feeds to them, and various other things. Hospital IT, hospital CIOs have figured out they need a data warehouse. Most of them don't have one. Most of them don't even have a strategy for getting one yet, but they're working on it. Okay, and so that's been widely recognized as, you know, we need a one-stop shop for all of this data, and we have to build that out. There's also an increased emphasis on building and getting to as few platform solutions as possible. So life is good for the ERP vendors, life is good for the electronic health record vendors, and even for companies like my own, where you're sort of trying to combine a lot of different planning functions together. And that's been viewed as, trying to sort of minimize the complexity there to get as much use out of data as possible. And so you can sort of think about then layering the classic sort of descriptive, predictive, and prescriptive analytics on top of that. Most organizations are still struggling at the descriptive level, but they recognize the need to move up the food chain. Let me talk first about descriptive issues in descriptive analytics, and I won't spend a lot of time on this because this isn't the audience for that, but it's a critical issue actually. The old approach, or the approach that a lot of organizations sort of get to naturally, is they've got clinical decision support systems of one type or another, and then they're producing quality reports, medical outcome reports, and so on. And then they've got financial data and financial information systems, and they've got financial DSS, and they're producing cost reports and financial statements and all the other kinds of reports you need to run the organization. And so if you're a department manager or a service line manager, you're getting at least 2 separate reports out of 2 separate reporting systems. And where things are starting to go is some kind of uniform reporting and analytics, and that's particularly critical in a new world where managing cost and quality together is important, because there is also some relationships between cost and quality. So if you have a lot of patients acquiring infections in their hospital stay, there's direct economic costs associated with that, as well as very real impact in terms of your quality stats and other things that are going to feed back into, are people willing to come to your hospital? Are they getting good care? Are you achieving your mission in that sense? And so getting to a uniform reporting and analytics platform is viewed as a pretty important thing, getting all the data in one place. And there's a lot of different models of how you do that. And so there's this notion we're going to have to get to something sitting on top of a unified data warehouse is going to have to be a unified reporting and analytics stack. Nobody's quite sure what that looks like. But even now, my company, which is primarily in the financial space, is pulling quality and clinical information in. Partly because if you want to know what it costs to provide care, it helps to know what the patient's diagnosis was and what procedures were run and so on. So just figuring out historically what was the cost of care, sort of classic activity-based costing, you've got to have access to the patient records, to the clinical systems, just to know what was done with the patient and what the supply costs were and so on. So you have to access those systems as well. And so now, you've got to pull it all together to do even that kind of fundamental financial analysis. And so now we're doing things like a single one-stop dashboard that has productivity statistics, expense numbers, and this might be a dashboard that a department manager would see, expense numbers, volume trends, and a quality indicator. This, in this particular case, this is actually an example from an actual client. If my software engineering people here, by the way, they would be cringing between when I did this slide and today. I did these slides about a month and a half ago. Between those 2 events, we rolled out a new user interface, which is much slicker and prettier, but they'll have to deal with that. The content would be the same. So what you see, for instance, is, well, we're above where we expected to be. The green is actuals, and the green is projected, and the blue is actuals. We're above where we expected to be on volume, but we're also above where we expected to be on expenses, and that's after flexing based on variable costs, so it's a flex budget indicator. And by the way, we're not hitting our target on, this is catheter associated urinary tract infections. We're not on our target, and that's a critical quality indicator that you look at in some hospital situations. Okay, so what's really important in making a reporting system effective is saying, okay, what are you going to do about it? Don't just send them the report, because what happens, they basically hit delete if it's an email, or put it on the shelf and don't look at it. Say, okay, well, you've got issues here, now tell me what you're going to do about it, what your action plan is, and then hold them accountable. So you need a unified reporting system. It's got to be digital reports, not paper, issued on a timely basis, self-service, and you've got to build some kind of accountability. Bake that into the process and the system around reporting. Tell me how you're going to fix it, and then let's look next month to see whether it's fixed yet, and so on. So track and monitor. Okay, so it has to be fast, compelling, self-service. That's really the big point I want to make here. There's a big demand for that. Right now, a lot of hospitals are doing reporting and analysis with old green screen mainframe systems, where there's one overworked or two overworked analysts in the basement. God forbids one of them gets hit by a truck, because nobody's going to be able to run these critical reports anymore. Okay, so so now they want it to be, okay, now I get this report, let me drill down and see which doctors are producing the activity that's problematic, which procedures, where there's some highly complex patients, what's really going on here, what procedures are being run. If I'm over on cost, is it because my doctors are picking more expensive medical devices where there's elective options on that, or whatever the case might be. And so let's really dig in and understand. And so you can't just have the analysts exploring and drilling into the data. That doesn't mean you don't need analysts, but you need much more self-service capability to make it a more effective system. And you have to turn these tracking systems into learning systems, systems that people can use to learn about their business, their organization. Okay. Most organizations aren't there yet, but they want to get there. Let's turn to the predictive side. Sort of what it takes to make good predictions. There's nothing stirring or stellar about this slide. Baselines, trends, relationships, assumptions, building out some models. A lot of it in our context tends to be financial models, so think large deterministic models like one would build in a spreadsheet, except delivered on a web-based platform with a database back end, so you're not juggling massive, ugly Excel sheets. Some caveats and concerns. I am a big fan of paying appropriate attention to data when you have data. I'm a bigger fan of not overlooking the fact that there are some situations where you don't have appropriate data. You have to use judgment. Preferably expert judgment, but if you look around and you can't find an expert, you're it. Okay, why? Well, think about healthcare reform. Healthcare is going to fundamentally change on January 1, 2014. It's about the 8th time in the last 15 years it's fundamentally changed. Okay. If I'm trying to figure out how many orthopedic cases am I going to have in my hospital versus in my orthopedics, my outpatient surgery, how many people are going to show up in my emergency room? Well, if I want to know how many people are going to show up in my emergency room next Saturday night, I really want some time series data, and we all know how to analyze that. If you want to tell me how many people are going to show up in my emergency room in 2017, which is a pretty critical number to do planning for capacity and things like that, I have no idea. And the data's not that helpful. It might provide a good starting point, a good baseline, but you better step away from the data and start getting some judgment, whether it's from your consulting partners or your best experts in the organization. And so you have to learn how to handle and incorporate subjective judgment, because there's no alternative. You have to plan. It's better to use subjective judgment in the context of models than just have a guy saying, with blue smoke coming out of his ears. It's what was the reference earlier, an 8-ball, somebody referred to in a presentation. They used to use an 8-ball. So modeling uncertainty in this environment is also a must-have. Explicitly modeling uncertainty. So I'm talking about probability distributions, Monte Carlo simulation, decision trees, whatever your favorite set of tools are for modeling uncertainty, use it. Why? Because the world is uncertain. And so the useful methods I've worked with hospitals on a routine basis include various kinds of scenario tools, automated sensitivity analysis, and Monte Carlo. Those are all sort of essential parts of our toolkit, but keep it simple. These are not the most sophisticated, most elegant models I've ever built. Why? Because they've got to use them. And in some cases, they've got to build the analyses and do the analyses themselves. Our biggest single success with Monte Carlo in a healthcare organization is Providence Health and Services. I think it's something like 40-some hospitals up and down the west coast of the US, basically from the San Fernando Valley in LA up to Alaska, to Anchorage. They require any project over $2.5 million of spend to get approval at corporate. And before it can get approved at corporate, it has to be put through our system for doing business planning with a rigorous financial analysis with sensitivity analyses and Monte Carlo simulation performed on it. Now, what do these folks, you know, a hospital CFO or director of finance at a small hospital in Western Washington know about Monte Carlo? Really very little. So we built out a system that took very little to be able to build out basic, simple analysis. Why? Because you're at least getting the dialogue started about, well, you can put in point estimates into your spreadsheet model, and out comes a point estimate at the end, and guess what? There's absolutely zero chance the world is going to turn out that way. But if you say, here's an input assumption, and here's a plausible range on it, and here's another input assumption, and here's a plausible range on it, now I've got something I can work with, right? Okay, now I've got at least a dialogue going on about how sure or unsure I am about the inputs and the outputs, and so on. So it's a start. And so just let me give you a quick example. This is actually a tool we've got that's used for producing board presentations around what's healthcare reform going to do to our organization. And so think about it as they have some baseline projection coming out of their financial models of where they thought net revenue was going to be in 2017. Net revenue is healthcare speak for revenue. It's how much you get paid, is how much you charge net of the discounts you have to make with all your payers. And so it's how much you actually get paid. Net revenue is actual dollars you receive. In any other industry, they'd call it revenue. It's net of discounts, and so it's the actual reimbursements you receive. So they say, okay, we're going to get $677 million in net revenue. But, oh, by the way, there's going to be this utilization shift from the ER and the hospital to outpatient. We think that's going to get to $20 million. How do they do that? Well, we have a guy in our shop who does modeling who spent a lot of time, way too much time, reading things like Congressional Budget Office estimates, talking to consultants that have been working in this space. And then they took those numbers as a starting point and layered in some judgment about local conditions, where they operate, and so on. And so that's good news. We think that's actually going to produce about $20 million in revenue, mostly by people showing up at the doctor's office that wouldn't have shown up before, people who now have that insurance card. But we're going to get paid less for that. We're going to get paid about $23 million less for that activity. So net, we're going to be worse off so far. And oh, by the way, readmission reductions. Okay, we're going to get dinged because we're not meeting the Medicare standards on readmissions, and we're going to lose $21 million with that, we think. That's our estimate. And value-based purchasing. That's basically the shift to the accountable care organizations and so on. That's going to cost us about $8 million, we think, on quality dings. And so here's our new projection, $645 million. And so that's our new reality. And so now we just opened up a hole, a fairly significant one in revenue if my operating margin is only 2 or 3%. And how am I going to cover that? What do I have to do in terms on the cost side to deal with that? A very effective tool, just a simple display like this for communicating. But oh, by the way, there's a lot of point estimates going into that projection. So we do things like automated sensitivity analysis, tornado diagram. Some of you may have seen this. Really simple. You could do this by hand if you were really patient. Take every assumption in your model that has a bound, or put a bounds around it, and then swing the model from one end of the bound range to the other, and plot out the range that's caused in the critical outputs that you're tracking in the model. So in this case, we're looking at net revenue in 2017, and then order the chart. The reason it's called a tornado diagram is it tends to form funnels. And so you order the chart based on the size of the swings. Probably want to pay more attention to the downside than the upside, but pay attention to both. So it's, you know, the way what we get paid for fee-for-service Medicare turns out to be the largest swing here. Well, that's the old model of payment for care. So that can be, the results can be surprising. This is not a sophisticated analysis. It's a very useful one. And it's easy to explain to a CFO or even a CEO if you talk slowly. Okay, so so it's a very useful tool. Provides a lot of insight, and sometimes the simplest stuff provides the most insight. Monte Carlo results, I do not show risk profiles, and I certainly don't show cumulative distribution functions to end users. Okay, but the kind of numbers, and particularly not to CFOs, board level people, and so on, the kind of numbers that are most useful come out of this kind of analysis, like, well, you know, we think there's a 50-50 chance that net revenue will be better or worse than the the decrease in net revenue will be better or worse than 35 million. Or, you know, we think there's an 80% chance that net revenue will decrease relative to it not increasing, or relative to it increasing. There's a 20% chance it might increase, but 80% sure we're going to have less at the end of the day once healthcare reform hits. And whatever, it's a very compelling, a few points out of a cumulative distribution make for a very compelling story. So what's the value from simple risk analysis? I'm still a big fan of sophisticated risk analysis, but what's the value from simple risk analysis? Focus attention on which uncertainties merit attention, very concise quantification of upside opportunity and downside risk, easy to communicate, easy to get across the idea that there is a lot of downside risk. Maybe you should start thinking about how you're going to manage that, strategies for managing it. And you can't manage risk if you don't measure. Almost out of time. Prescriptive analytics, we've done a lot of work, and I've talked about it to this audience before on capital allocation. Think of it as a knapsack problem if you're an optimization fan. You've got limited resources, much more requests for those resources than you have resources available. Okay, so what do you do about that? Build an optimization-based system. It took me about 3 days to build it once we had the idea to do it. It took me then years to build out the rest of the IT infrastructure and the process and workflow around how you actually make it work in a hospital. Okay. How do you get all the information? How do you get it implemented in a way that people understand it and believe it, and so on? How do you build a process for allocating resources when you've got $12 million to spend and $60 million in ask for that spend on capital equipment, on medical technology, on IT, on bricks and mortar, on new business projects, and so on. You've got to allocate that out. So you've got fundamental objectives like outcomes and quality. You've got means objectives like return, infrastructure, staff and physician relationships. Anybody who understands optimization knows question one is, what's the objective function? And you better get it right. Well, in this case, because this is a not-for-profit health system, it's not maximizing profit or minimizing cost. Okay? It's maximizing some combination of quality of care and number of people you're taking care of. But, by the way, there's an expression that comes out of not-for-profit healthcare: no money, no mission. Right? If you don't make enough money to keep the doors open, you're not going to provide good care or a lot of care. So you better pay attention to that. And oh, by the way, you need a good building and an infrastructure and something that can handle all the fancy new medical technology. And you need enough space. And you also need doctors and need to keep them on hand as well. So how do we do this? We build out a multi-attribute, and I'll skip this slide. We build out a multi-attribute value function to aggregate across multiple measures using judgment. Okay, using 0 to 100 impact scales. Why? Because we didn't have better data, or readily accessible better data that was comparable across all the projects. Everybody scores the projects, put weights for relative importance of the different objectives, and then there's an optimization system that basically solves the knapsack problem. Gets as much cumulative benefit using this aggregate linear score, weighted linear score, subject to budget constraints, subject to some other side constraints, and it can get fairly elaborate in terms of building out the optimization system. Having said that, if you want to hear stories about solving really complicated, messy integer programming problems, talk to somebody else. Okay, I've never had a solution time of more than a second, with the possible exception of an open source Excel solver where it might take maybe if it's a really complicated one. It's just not. You know, these are not hard optimization problems. Having said that, a lot of this is done real time in front of the C-suite where they're making the decisions. We run the optimization, show them the results, and this is apologies to those in back, this is a screenshot of the system's output, and the green checks mean it recommends funding, the red X's means it doesn't. There's two scenarios side by side. We run a baseline scenario saying you have this much money, this is what it recommends funding. Now let's talk about the stuff in the middle, right on the bubble. And this is sorted based on benefit score per dollar spent. Why? Because it turns out that's a good heuristic solution to a knapsack problem, to a simple knapsack problem. It's a helpful metric to interpret the results. And it says, okay, well, somebody might say, you missed it on this project. It's a cardiology PACS system. Okay, you didn't get it, it's really important, and so you say, okay, let's try it again, but now let's force that into the solution set, rerun the optimization and see what happens. And the answer is, yeah, we can force that in, but now we're going to lose this, and in this project. And what does that mean? Well, now we have to talk about that, and you've made the opportunity costs really clear, really dramatically apparent. You can fund this, but not that. So I'm running out of time, so let me pretty much wrap it up here. That's a very simple sort of thing, but it feeds the dialogue and makes life a lot easier. So let me sort of say, what are the sort of the key lessons learned here? One, process transparency helps. Okay, it makes a big difference. Building a clear process, clear ground rules, getting away from black box models, and producing results that at least appear to be accessible, understandable. Okay? It's a multi-year process to help an organization get to this way of thinking about the world. Some organizations are easier than you might think. Academic medical centers, the doctors tend to think of themselves as scientists. They like a more analytic approach. Okay? That helps. Focus on collaborative systems and processes. That's probably the biggest one. It has to be about collaboration, about information share, about getting everybody together in the room, or at least figuratively together on the same information set, seeing the same things, get cross-functional teams talking together. Executive teams using real-time analysis, actually doing the what-ifs themselves, driving the discussion about the what-ifs is very compelling. If you have a model that takes hours to solve, it's not so compelling. But if you've got a model that solves quickly, and this maybe is an advertisement for simple models, then that's a very real option. Okay, or if you buy enough computing that you can solve it quickly, if that's theoretic, if that's possible, and use the process to improve communication and trust in the organization. Okay. That makes a big difference as well. Let me stop at that point. I don't want to run over time too badly. Thank you very much.